Hi, my name is Tara Donaldson, and I'm here to talk to you today about pulmonary emboli. A pulmonary embolism starts as a clot somewhere else in the body, most often in the deep venous system of the lower extremities. It can also start in the renal vasculature or in the deep veins of the upper extremities. The clot dislodges from its original site and migrates into the pulmonary vasculature, causing obstruction of the pulmonary blood flow. PEs can also come from air, amniotic fluid, fat, foreign bodies, parasitic eggs, tumor cells, or septic emboli from infective endocarditis. In this presentation, however, we'll be focusing on PEs caused by thromboemboli. PEs are the third leading cause of cardiovascular death in the US and the third leading cause of death among hospitalized patients. Approximately 900,000 people are affected annually in the United States, and 100,000 of these will die. The number of deaths caused by PEs are likely underestimated, though, as severe PEs can cause sudden death and autopsies are not always completed. The incidence is higher in male patients, and the incidence rises in age, especially among women. By the age of 75, the incidence is greater than 500 cases per 100,000 people. The incidence of PE is also higher in certain populations, including cancer patients, those who are pregnant, those with inherited thrombotic disorders, patients who are hospitalized with stroke or other medical conditions, or after surgical procedures, especially gynecological or orthosurgeries. Patients with traumatic spinal cord injuries are also at higher risk for PE. So, how does a PE form? Virchow's triad consists of venous stasis, endothelial injury, and a hypercoagulable state. These three issues create the necessary conditions for the form of venous thrombosis. If you look at the diagram in this slide, you'll see examples under each of these parts of the triad. Under hypocoagulability, you'll see major surgeries and traumas, malignancy, pregnancy, sepsis, estrogen therapy, genetic thrombophilic disorders, and other inflammatory conditions. Vascular damage can be related to venipuncture, indwelling venous catheters, cellulitis, and physical trauma. And a patient may have venous stasis due to immobility, venous obstruction from obesity, tumors or pregnancy, varicose veins, atrial fibrillation, bradycardia, or congenital venous abnormalities such as AVMs. The risk factors for PEs are really the same things that we just talked about in the diagram. There are many genetic risk factors, such as factor V Leiden, sickle cell anemia, and the prothrombin gene mutations. Acquired risk factors are characterized as provoking or non-provoking. Provoking risk factors are things like surgery, trauma, immobilization, active cancer, or the initiation of hormone therapy. All of these create a hypercoagulable state or venous stasis. Non-provoking risk factors are those that increase the risk of vascular damage, such as obesity and heavy cigarette smoking. Most emboli come from the lower extremity proximal veins, but DVTs can less commonly form in the renal or upper extremity veins. The most common sites in a vein for a thrombi to form are the valve cusps and bifurcations. Pulmonary emboli are typically multiple, and the lower lobes of the lung are most often involved. Once the thrombus lodges in the lung, several pathophysiological responses can occur. The size and the location of the thrombus play a role in the consequences of the PE. In about 10% of patients with PE, small thrombi lodge distally into the segmental and subsegmental vessels of the lung. This results in pulmonary infarction. These patients are likely to present with pleuritic chest pain and hemoptysis related to the inflammatory response to the infarction. PE causes impaired gas exchange within the lungs due to the mechanical and functional obstruction of the vascular bed that alters the ventilation to perfusion ratio. Inflammation in the lung causes surfactant dysfunction and atelectasis. These processes cause hypoxemia. Increased pulmonary vascular resistance is caused by the physical obstruction of the vascular bed by the thrombus and the hypoxic vasoconstriction within the pulmonary vascular system. Diminished stroke volume and cardiac output are the results of the increased PVR, and lead to the hypotension that is often a presenting symptom of severe PEs. If severe enough, the patient may show signs of shock or may have cardiac arrest. There are many ways to prevent PEs, although a PE can still develop despite our best efforts. Each person can do some things individually to decrease their risk, such as quitting smoking, losing weight, wearing compression stockings, elevating their legs, ambulating frequently and getting exercise, and standing up and moving around while traveling long distances. As NPs, we need to educate all of our patients about these risk reduction techniques. Nurses can also do some simple interventions while a patient is hospitalized to help decrease their risk of forming clots during this time of higher risk. As providers, we will need to order these interventions, which will include the application of SCDs or compression stockings and progressive ambulation protocols. We can also order pharmacologic prophylaxis, including low molecular weight heparin or enoxaparin, heparin, or fondaparinux. These can be used during inpatient stays to prevent DVT and PE formation. If the patient is admitted for specific surgical procedures that cause an increased risk, they may go home with Lovenox or a DOAC to be prescribed for a period of time. PEs have a wide variety of presentations, ranging all the way from incidental findings with no symptoms to sudden death. The most common presenting symptom is dyspnea, and other common symptoms include chest pain, specifically pleuritic pain on inspiration, cough, other respiratory symptoms such as tachypnea or wheezing, and symptoms of DVT. Hemoptysis is possible, but not frequently seen. The patient may also present with a decreased level of consciousness, arrhythmias, shock, or cardiac arrest. When a patient presents with any of these symptoms, especially with dyspnea, the provider should consider PE as a part of the differential, especially when risk factors are present. When a patient presents with dyspnea, chest pain, cough, and tachypnea, what are some other diagnoses that we should consider? Chest pain and dyspnea could suggest acute MI, acute pericarditis, AFib with RVR, an exacerbation of CHF, and pulmonary edema. Adding tachypnea could be suggestive of anxiety or a panic attack. Cough with dyspnea is seen with lung cancer, emphysema, and ARDS. The most important of these to rule out are the can't-miss diagnoses, which are acute MI and ARDS. PE is also a can't-miss diagnosis. In the next slide, we'll look at how we rule out these diagnoses and rule in pulmonary embolism. Risk stratification is an important part of the workup for PE. With any patient that presents with symptoms suggestive of PE, the Wells score and Perks score should be calculated to see whether PE is a likely diagnosis. The Wells score is a clinical prediction rule for PE. It assigns values to several clinical variables to determine the pre-test possibility that a patient has a PE. The variables considered are clinical signs and symptoms of DVT, whether any alternative diagnosis is less likely than PE, the presence of tachycardia, recent immobilization or surgery, a history of DVT or PE, cancer, and hemoptysis. Each of these is assigned a point value, as seen in the image, and when added together, they determine the probability index. The Wells score is the most commonly used clinical prediction tool for PE. Greater than 4 is the score considered likely to be a PE. Patients with values 4 and above should get definitive imaging to confirm the diagnosis. The Perks score is calculated to identify patients for whom no testing is needed. It is used with patients who have had a Wells score of less than 4. If all the criteria in the PERC are present, PE is excluded as a potential diagnosis. I've also included in this slide the PE Severity Score Index, or the PESI score. This tool is used once the diagnosis of PE is confirmed and used to predict patient outcomes. It helps us to know who is appropriate for outpatient management and who we need to consider admitting to the ICU for care. The diagnostic process for PE is algorithmic. We start with the Wells score discussed in the previous slide. Patients with low to intermediate risk of PE based on the Wells criteria should have labs drawn, specifically a D-dimer. Since the risk of PE is low to intermediate, we should also collect a CBC, BMP, and troponin at this time to help us narrow down the differential diagnosis if the D dimer is negative. Troponins will be positive in up to 25% of patients with PE, so these results are also useful in risk stratification if the patient is found to have a PE. The D dimer is not as useful for patients who have already been admitted to the hospital due to the higher rate of false positives, so this algorithm works better in the ED setting for initial patient presentations. A positive D dimer is greater than 500. A positive test in this patient group should be followed by definitive imaging studies. A finding of less than 500 excludes PE. In patients who are high risk based on the Wells score, or for low to intermediate patients who have a positive D dimer, the next step is definitive imaging. The preferred option, if available, is a CTA. If unavailable at your facility, or if the patient is unable to be transported due to their condition, other options include an ultrasound of the chest or VQ scanning. A chest x-ray can be done to assess for other diagnoses, but will not show a PE. Positive imaging, other than on the x-ray, confirms the diagnosis of PE. Negative imaging will rule it out. When deciding which imaging option to use to assess your patient, remember that CTA is the gold standard. However, transporting a hemodynamically unstable patient to the CT scanner may not be a viable option. In such a case, bedside echo or duplex ultrasound of the legs for DVT provides the necessary diagnostic information. The initial approach to suspected PE should focus on stabilizing the patient while clinical evaluation and definitive diagnostic testing are done. The first step is determining the patient's hemodynamic stability. A patient who is hemodynamically unstable is hypotensive or has clear evidence of shock. As mentioned earlier, the diagnostic approach is determined by the patient's stability. A patient who is unstable should have bedside echo or venous duplex ultrasound to diagnose the PE, while a stable patient should have labs drawn, especially a D dimer, and then be transported for a CTA or VQ scan. When the diagnostic efforts are being made, the patient needs to be stabilized. This includes respiratory support by administration of supplemental oxygen to an oxygen saturation of over 90%. In a patient who is severely hypoxemic and showing signs of hemodynamic collapse and/or respiratory failure, intubation and mechanical ventilation are required. A patient whose right ventricle is showing signs of failure will do best if cardiovascular anesthesia is present and high plateau pressures are avoided. The patient also needs to receive hemodynamic support. This is achieved through small volumes of IV fluids, usually 250 to 500 mL of normal saline, and vasopressors if the bolus did not correct the patient's status. Norepinephrine is the generally preferred pressor. Finally, empiric anticoagulation should be initiated as soon as possible if the patient is low risk for bleeding. Patients who are intermediate risks should be considered on a case-by-case basis. Unfractionated heparin is the best choice for initial empiric anticoagulation. In hemodynamically stable patients, patients with a low risk of bleeding should receive anticoagulant therapy. It should be initiated as soon as possible to achieve therapeutic levels. All patients will need to be anticoagulated for a minimum of 3 months. Some patients will require indefinite anticoagulation, and this decision is related to the presence of persistent risk factors and if the PE was unprovoked. Some patients who are in stable condition can be anticoagulated on an outpatient basis as determined by the PESI score. The patient must also be able to understand the treatment protocol and be mentally and physically able to self-administer the treatment. For patients with contraindications to anticoagulation or who have unacceptably high bleeding risk, an inferior vena cava filter should be placed. IVC filters should also be used in patients who have a recurrence despite therapeutic anticoagulation. IVC filters will not be effective for patients who have upper extremity or renal thrombi. For these patients, a superior vena cava filter or a suprarenal filter should be used. For patients with a moderate or high risk of bleeding, the therapeutic decision should be individualized. Thrombolytic therapy is recommended for hemodynamically unstable patients to reestablish perfusion. Systemic thrombolytic therapy is widely accepted for patients with PE who are present with or become hemodynamically unstable due to PE. The therapy can be delivered via a catheter directly into the thrombus if an experienced provider is available. Otherwise, it can be delivered via IV into the systemic circulation. Embolectomy is indicated in patients who are hemodynamically unstable and thrombolytic therapy is contraindicated or was not successful. Low molecular weight heparin, or Lovenox, is given subcutaneously. This option is preferred in patients in whom oral anticoagulation is not feasible, such as those with malabsorptive disorders or poor oral intake, or is contraindicated, such as in the case of pregnancy. Low molecular weight heparin is the preferred choice for patients with active malignancy as well. DOACs are also an acceptable option in this population. Dosing for low molecular weight heparin is weight-based and renally adjusted. Enoxaparin 1 mg per kilogram twice daily or 1.5 mg per kilogram once daily in non-obese patients is the dosing that is used. For outpatient treatment, the twice daily regimen is preferred. Low molecular weight heparin has been shown in several trials to have higher rates of thrombus regression and lower rates of recurrent thrombosis, major bleeding, and mortality compared to other anticoagulation options. Fondaparinux is another subcutaneous injection that is an acceptable alternative to low molecular weight heparin. This should be used in the case of patients with a history of heparin-induced thrombocytopenia, or HIT. It should not be used in pregnant patients. Fondaparinux is typically dosed based on the patient's weight as 5 milligrams once daily if under 50 kilograms, 7.5 milligrams once daily in those 50 to 100 kilograms, and 10 milligrams once daily in patients over 100 kilograms. The efficacy is similar to that of enoxaparin. Unfractionated heparin is administered IV in the inpatient setting and requires frequent labs to maintain a therapeutic level. This is the preferred anticoagulant in patients with renal failure, extensive clot burden, and hemodynamic instability. Unfractionated heparin is preferred in unstable patients since it is quickly reversible if the decision is made to pursue thrombolysis or embolectomy. Obese patients are best treated with unfractionated heparin because the measurement of therapeutic levels ensures that they are getting complete anticoagulation, whereas other options may be more difficult to ensure adequate dosage. Initial dosing of heparin is weight-based but unaffected by renal function. The infusion is adjusted based on achieving and maintaining a therapeutic APTT range, which is 1.5 to 2.5 times the normal level. The efficacy depends on achieving a therapeutic level as soon as possible. DOACs, or oral anticoagulants, are acceptable for the use of treating PE and include Xarelto and Eliquis. Either of these are approved for use as monotherapy. These are good options for patients who are unwilling or unable to give themselves injection therapy. Lovenox or unfractionated heparin should be administered in the interim if there is a delay in starting the DOAC. These agents should not be used in patients who may receive thrombolytic therapy or in those who are pregnant. DOACs are not suitable therapy for hemodynamically unstable patients or in those with massive iliofemoral DVTs. Dosing for Xarelto is 15 milligrams twice daily, and Eliquis is 10 milligrams twice daily. Thrombolytic agents activate plasminogen to form plasmin, which accelerates the lysis of the clot. This therapy is used to rapidly dissolve a clot and improve cardiorespiratory hemodynamics. Thrombolytic therapy, however, is associated with bleeding that can be catastrophic. Patients must be carefully selected for this treatment. Only patients who are hemodynamically unstable, have a high likelihood of or confirmed PE diagnosis, and who have a favorable risk-benefit profile should be considered for this therapy. A multidisciplinary team of experts should confer to make the decision to administer it. Consideration of the use of this therapy should include the risk of death from PE and the risk of bleeding from the thrombolytic agent. High-risk patients who are hemodynamically unstable and at high risk of death from PE are considered good candidates for thrombolysis if the risk of bleeding is low. Patients who are unstable due to PE but who have a moderate or high risk of bleeding can benefit from catheter-directed therapies with or without thrombolysis rather than full-dose systemic thrombolytic therapy. Intermediate risk candidates have a PE associated with biochemical, echocardiographic, and/or imaging evidence of right ventricle dilation or hypokinesis without systemic hypotension. Candidates within this group have an abnormal right ventricular function and elevated BNP or troponin are more likely to benefit from thrombolysis. Low-risk patients should not get thrombolytic therapy. They should be treated with anticoagulation alone. Absolute contraindications to systemic thrombolytic therapy include intracranial neoplasms, intracranial or spinal surgery or trauma within the past 2 months, history of hemorrhagic stroke, current active bleeding, severe thrombocytopenia, and ischemic stroke within the past 3 months. Relative contraindications include severe uncontrolled hypertension, non-hemorrhagic stroke more than 3 months before the PE diagnosis, surgery within the last 10 days, and pregnancy. For patients in whom contraindications or high bleeding risk truly prohibit thrombolytic therapy, an IVC filter and catheter or mechanical or surgical embolectomy should be considered. Once the decision has been made to treat the patient with thrombolytics, this therapy should be administered as soon as possible. This is accomplished with systemic infusion of tissue-type plasminogen activator, or TPA. Alteplase is the most common drug in this class. IV access needs to be secure, and peripheral access is acceptable for this indication. If the patient is already on a heparin infusion, it should be discontinued immediately before and during the thrombolytic infusion to minimize the risk of bleeding. It can be restarted once the infusion is complete. The patient can be transitioned to a DOAC after they have been stable for 24 to 48 hours. TPA can be dosed in 3 ways. The most common way is 100 milligrams IV over 2 hours. In more urgent situations, however, it can be given as a bolus infusion over 15 minutes or as a 50 milligram IV bolus followed by the other 50 milligrams over 2 hours. Improvement is generally seen in the first hour of therapy. During the infusion, the patient should be monitored closely for stability or improvement in vital signs. They should also be monitored for signs of bleeding, including new neurological deficits, declining hemodynamic status, or obvious bleeds. Signs of major bleeding require immediate stopping of the infusion. Minor bleeding, however, is common and acceptable, especially at puncture sites and the gums. 10 units of cryoprecipitate with or without 2 units of FFP can be used for refractory bleeding. Thrombolytic agents can also be infused directly into the pulmonary artery via a pulmonary artery catheter. This catheter-directed therapy allows lower doses of thrombolytics to be administered, lowering the risk of bleeding when compared to systemic therapy. Embolectomy can also be performed using a catheter-directed approach. Both of these procedures are performed through access at the internal jugular or femoral veins, and they require providers with appropriate expertise to perform them. These approaches are options for patients with persistent hemodynamic instability despite systemic thrombolytics and those who are unstable but also too high a risk for bleeding to be administered thrombolytics. Both of these options are high risk, but they are used because the other option is likely death. After initial treatment, survivors of PE will require significant follow-up care because they will be on long-term anticoagulation. Some patients, as we discussed, will require lifelong anticoagulation, while others will be treated for 3 months. Follow-up care will require educating the patient on the importance of taking their anticoagulant medication and monitoring the continued anticoagulation. The DOACs used after PE do not require lab monitoring like warfarin. 1 to 2 weeks after discharge, the patient should be seen in the follow-up clinic to begin working up the cause of the PE and the risk of recurrence. Recurrence is considered an early complication of PE, which is why continued therapeutic levels of anticoagulation are so important. A late complication of PE is chronic thromboembolic pulmonary hypertension, or CTEPH. Most patients who develop CTEPH do so in the first 2 years after the PE, and clinically persistent symptoms should cause the clinician to suspect this complication. Monitoring for these symptoms, as well as for complications of anticoagulation therapy, such as bleeding and medication adverse effects, should be done at every follow-up appointment. If the patient had an IVC filter placed because the anticoagulation was contraindicated, they should continue to be assessed at follow-up for resolution of that contraindication. Once this is seen, the patient should be scheduled for removal of the IVC filter and then started on a DOAC. The incidence of PE, as mentioned previously, increases with age. PE is not an uncommon acute cause of death in the elderly, yet it is frequently missed in diagnosis. This is usually because more common disease processes, such as COPD, CHF, and pneumonia, are assumed to be more likely. The most frequently seen symptoms of PE in the elderly are dyspnea, tachypnea, tachycardia, and chest pain. These are similar to symptoms you'd see in younger patients with PE, but they are also similar to symptoms seen with the previous mentioned disease processes. Chest pain is seen less frequently in elder patients, while tachypnea and syncope are more frequent than in younger patients. Bed rest, surgery, and cancer are the most frequent provokers of PE in elderly patients, but bedridden elderly patients are infrequently prescribed medications or mechanical prophylaxis. D-dimer is not as specific in elderly patients as it is in younger patients. This is because elderly patients have a D-dimer higher than the cutoff at baseline, but increasing the cutoff point would increase the percentage of false negatives. EKG, chest x-ray, and echo are also less diagnosis in the elderly than they are in younger patients. As such, CTA is the best method of diagnosing elderly patients with PE. It has been a common practice to decline to treat elderly patients with thrombolytic therapy because they are believed to be too high a risk of bleeding. However, studies have shown that elderly patients with massive PE, right ventricular dysfunction, and hemodynamic instability should be treated with thrombolytic therapy unless they have an absolute contraindication. The final consideration for our geriatric patients is long-term anticoagulation after the diagnosis of PE. Xarelto has been found to be safe and effective in the elderly population, and the small tablet is easier for a patient with arthritis to administer versus a Lovenox injection. An important role that nurse practitioners play is that of patient advocate. One of the ways that we can do this that would have the biggest effect on the most patients is to advocate within our hospital's administration to establish a PERT, or a Pulmonary Embolism Response Team, in the facility. The purpose of a PERT team, just like a stroke team, is to bring a multidisciplinary group of experts, including pulmonologists, intensivists, cardiologists, thoracic surgeons, interventional radiologists, vascular surgeons, ED clinicians, and pharmacists, to respond to suspected PE situations, to facilitate rapid diagnosis and management, as well as determine candidates for thrombolytic therapy. Establishing a PERT team in your facility would help get urgent care to people quickly when they have a suspected PE. Other ways that we can be advocates for our patients are to educate them to be advocates for themselves by teaching them preventative methods and educating them on the treatment options to assist them in making the best decisions for their own health care. I'd like to thank you for listening to this presentation. I know as acute care NPs, we are very likely to see PEs in our practice, and I hope that this will help you be ready for that situation when it comes.